Nou, dames en heren, dat is de begintune van de Grand Rounds. Daar heeft u van kunnen genieten. Hartelijk welkom op deze inmiddels alweer 14e Grand Round. Fijn dat u allemaal gekomen bent in toch grote getalen, ondanks het mooie weer buiten en de zomerse omstandigheden. En we hebben vandaag een speciale gast en ik zal ook in het Engels overschakelen om haar te introduceren. Professor Dickerson, it's a great honor for us to invite you here at this Grand Round session. We are very glad that you've come to Nijmegen and will present the 14th Grand Round. Professor K. Dickerson is epidemiologist in Johns Hopkins University in Baltimore, and she's also the chairman of the Center for Clinical Trials and chairman of the US Cochrane Center. And she's very active in the field of patient empowerment. And this afternoon she will talk about the tension between evidence-based medicine and person-based medicine, and she will talk with us and discuss with us how we will bridge that gap between these two concepts. Professor K. Dickerson, the floor is yours.
Thank you. It's very nice to be here. And you all are clinicians. I'm not a clinician, so I'll look to you for help. I'll give you the research perspective as we talk. I work in public health, I work with clinicians, so it's a wonderful pairing and partnership, but I do look to you for the clinical view when we get to the question point. All right, this is new for me that I touch the screen to move the slide. Okay, so I just thought I'd go over some of the definitions just so we're all on the same page. How many of you are completely comfortable with the idea of evidence-based healthcare? And I'm calling it evidence-based healthcare to go beyond medicine, to go to nursing, to go to dentistry, to go to physical therapy, the different areas of health and not just medicine. So that's why I call it that. But how many of you are completely comfortable with this sort of idea of evidence-based healthcare? Okay. Good. So the whole idea, there are many definitions out there. This is the one I like best because it's not just that the evidence tells you what to do, it's that it's one of several things. There's research evidence, there is the expertise that the clinicians have, that they've learned in their medical school and their training and residencies, but also in their day-to-day experience and reading. And then there's also the patient values and the clinician values also, although it's not on this graph. So values are brought to decision making. So it's fine, I as a patient want to know what the evidence is and what my clinician thinks when I have a decision to make, but I'll bring to that decision my values as well. Now, typically there is what is the evidence, and typically there's a process. We go from the creation of knowledge, evidence generation, which might be first the preclinical studies in animals and clinical trials, observational studies, and then they're synthesized in something called systematic reviews, which is like the notion of reviews, the literature reviews, but it's systematic. It has a methods section, a systematic review, and a results section, discussion section. So it's systematic, trying to find all the evidence on a question. And so you wouldn't practice on the basis of a single clinical trial. You'd look to see all the evidence at one point. And from there, we get, at least in the US, clinical practice guidelines, and NICE has guidelines in the UK. Do you have guidelines here that you practice from? And I might use the abbreviation. I'm very conscious that I have some abbreviations on these slides. CPG, Clinical Practice Guidelines. And so guidelines should be based on systematic reviews and the evidence. In the US, this is a challenge for us, finding that balance between expert-based guidelines, and when there's evidence, it probably shouldn't be expert-based, but there often isn't evidence that we want for questions that we're asking. And then finally, and this is the hardest part, applying the evidence in practice. At least this is where we have a hard time in the States, making sure that policy is applied. Based on what we know. Okay, so personalized medicine, well, there are lots of definitions, and I chose this one. but you probably know of another one that's maybe just as good, maybe a confusing one. But I'm saying that it's a tailoring of medical treatment to the individual characteristics of each patient. Now, what that means is classifying the patients into subpopulations that are differ in their susceptibility, either to a disease or to the treatment, their response to a treatment. It's not creating drugs or medical devices that are unique to each patient. So I went on the internet. I love the internet. It gives all sorts of images, and I went into Google Images and I put personalized medicine to see what it would give me. And this one seemed the closest to my definition. That is, you have a patient group and all these different kinds of people who react differently to a drug. There may be some for whom the drug is toxic, but it's beneficial. Some for whom the drug is not toxic, but neither is it beneficial. Some for whom the drug is it's toxic but not beneficial, and then some for whom the drug is not toxic and beneficial. Those are the lucky ones. So at the same time that I went into the internet and found that definition and picture, I also found that a lot of the pictures that are out there define personalized medicine as relating to one's genes. So I'm not taking that view of it. I think that that was the initial idea maybe 5 years ago, was, oh boy, if we know everybody's genome, then we can get them the medicines that fit their genome. But it's just unrealistic. I don't think it's even realistic for 10 years from now. But it is realistic to start looking at subgroups for whom will benefit most. So knowing a genetic profile can sometimes help you choose a treatment and tailor it. For example, women who have breast cancer and are positive for the oncogene HER2/neu respond to the drug Herceptin, and that drug Herceptin was designed especially to be an antibody against the oncogene HER2/neu. And so that's one of the very few examples of where genomics have been useful in tailoring drugs to specific people. I believe about 30% of women with breast cancer are positive for that gene. So it's very useful there. But this was when I went on the internet. I should have one more. Okay. But this influence of the genome at this point on the drug response is often quite small. There are alternate pathways. There are many ways, maybe more than one gene that are affecting a particular condition. And so it just doesn't work all the time, at least not now. And one of the problems with doing genetic screening, and people are being encouraged to do genetic screening for Alzheimer's, at least in the US and other things, is that it will lead to more tests. As any of you have taken epidemiologie 101 know, when you test a low prevalence population, you get a lot of false positives, and they have to go through a whole series of tests to show that, in fact, they don't have a condition that you're looking for, and some of them will be treated unnecessarily. This is a snapshot. You can't see anything in particular. Maybe if you can squint, you can see that almost all the pictures under Google Images for personalized medicine had DNA in them. There are variations on DNA, and my favorite actually isn't here. And the DNA is made up of dollar bills. And so it is a way to increase revenue by doing more tests. And so people are concerned about this as well. So did you all get the story over here of Angelina Jolie a couple weeks ago? So her mother died of ovarian cancer in her 50s, 56, and her aunt just died of breast cancer, and she's positive for BRCA2. And so she decided to have prophylactic mastectomy. And she wrote an editorial in the New York Times about this. Well, was that a good decision? You know, this is, one could say, personalized medicine. I don't know if it was a good choice or not, but I think she is in a bind with small children. But I went to the Cochrane Review to see what the Cochrane Review says, and it says that it should only be considered amongst those at very high risk. And it appeared that she is at high risk. risk with both her aunt and her mother dying young of ovarian and breast cancer. But that the evidence only comes from observational studies, not randomized trials, that this is bilateral mastectomy would be something to do to prevent death, and says there's insufficient evidence that it improves survival, and studies are needed because of the many confounding variables. We don't know the penetrance of the gene, especially in the next generation, but I think with young children, she just decided she didn't want to take the risk. So I'm not making a judgment here, but it certainly has increased screening and genetic screening for many women in the aftermath. So genetic screening and the data can often raise questions too. This is an example from the FDA where they have on the label for the drug clopidogrel that if you test positive for this gene, then maybe you won't be able to, the drug won't be as effective for you. It's an anti-clotting drug. And so doctors should do this test before they prescribe the drug. Well, there's a systematic review that came out a couple years ago in JAMA that showed that, in fact, there wasn't an association between genotype and cardiovascular outcomes, which is what people were worried about with presence of this gene. And so the FDA was worried about this. They said, well, you know, based on the data that we've looked at from the company, we think there is a potential danger. What should we do? Where this systematic review shows that there is no danger, and what we see in the data the company has sent us, there appears to be a danger. So sometimes more questions are raised than answers when you have genomics being used. And I don't know the answer here. What they asked me to come and advise them on whether it's a problem of publication bias, and all I could really say was it looked like a pretty well done review, actually. So I don't know why they're getting different answers. So, but personalized medicine, the way that it's done now, or personalized care, is looking at risk assessments. So one of the problems is that patients have many, many attributes and many things that'll have them respond to a treatment, for example, or not. And you can't put them all into a big equation. It's just too hard. There are things you don't know about, and even when you do know about them, it's too many things mathematically, statistically to manage. And so what do? So people come up with risk prediction models that they can use that then predict which subgroups will react best to which treatments. And this is what's being used now. So here's an example from a trial of tiotropium on forced expiratory volume in patients with COPD. And what they found in subgroup analyses is that patients who are taking inhaled corticosteroids or long-acting agonists at baseline, then it doesn't work as well. And it works better if patients are not receiving these drugs at baseline. And so what the results of this trial mean then that if they do the study again, because that's a hypothesis-generating exercise, they found this out in a subgroup analysis of a randomized trial, so they do another trial, then they should find that the drug is more effective in people not receiving these drugs at baseline. But what it doesn't mean is that doctors should now take their patients off of these drugs and take them off of inhaled corticosteroids and long-lasting agonists before they're put on the drug. So it means that in trials going forward, prospectively, what the patient is taking at baseline is likely to be meaningful in terms of how well the drug works, but it does not mean, the results of the trial do not mean take your patients off these drugs that they're already on and give them a new one. So I think that, and this will be a theme that I say throughout what I'm talking about, is we have to truly understand what the statistics are telling us before acting. And that means better partnerships between the statisticians, the public health people, and the clinicians. So this is a study by Tong Yu and Milo Puhan who did his PhD here in the Netherlands, and what they did is they looked at guidelines in the US to see how many of them actually use some of these risk prediction models. So we have the clinical practice guidelines. Are they sort of very basic overall looks, expert-based and evidence-based, but they don't go far enough in terms of looking at the risk prediction for patients in specific subgroups. They only looked at heart disease, just adults, heart disease, cancer, stroke, COPD, and diabetes, and they just looked for the US, Canada, and NICE guidelines. And what they found is that very few of the guidelines, and there were a lot out there, actually use risk assessment tools, most of them in the cardiovascular disease area. So these are modeling procedures that are just beginning to be looked at and incorporated, and I would say it's a fairly small number of groups that are looking at risk prediction. And so you want to find a group that can do it right when they go about making these models. So this is one of the problems that I'm going to talk about now, which is if we're going to be personalizing care, then we have to make sure that the data that we're basing the care on is correct. And this is a problem, actually. I'm going to talk mainly about randomized trials because it probably is the best evidence for knowing whether an intervention works, because since you randomize, the two groups are similar on both known and unknown confounding variables and on the reason they were selected to get the treatment. But systematic reviews of trials, then, they depend on trying to find all possible trials. If you're looking at trials, systematic reviews can be done with observational studies too, but say we're in the trials world, you really want to be able to find all of the studies, not just some of them. And that's because it's hard to find all of them, and for that reason, the ones that are hard to find may be different from the ones that are easy to find. So the solution is we go and try to look for absolutely all of them. But the clinical trials aren't necessarily easy to find, and the systematic reviews aren't necessarily well done. So we have a problem there, and that's what I'm just going to show you now. So this is just from a non-trial. This is a systematic review that I was involved in recently, looking at spirometry and the difference that are accepted worldwide between white race and other race and ethnic groups. And I think in general, whites are thought to have a higher lung function than other races and ethnic groups. And when we did a systematic review of all the studies examining this, we found 226 articles, and most of them, the vast majority, found that whites had higher respiratory function and lung function, and the others found sometimes no difference, that whites were lower. It is very sensitive, or variable values. But only 17% of the studies defined race. So they're finding whites have a higher lung function, but they never defined race. What's white, what's black, what's whatever race or ethnicity they used. And so these are unreliable results. And so now we have in our spirometry machines, it's programmed into it. You put in age, race, sex into the machine, and you get a normal value back, and there is a race correction there based on these studies that didn't define race. And so the underlying substrate that we have for personalized medicine is very weak. I should say also, I don't have a slide on it, that these studies, for the most part, used literature controls and didn't use parallel controls at the same time. So it compared, for example, the racial group they were looking at with what's in the literature. So these are very weakly designed studies, and mostly because they didn't define race or ethnicity in them, and still we're deciding treatments on the basis of them. So this is an area that people talk about a lot, and I have to say I don't see a way to solve it, and maybe you all can help. And that is the question that we're asking in a study. Now, when you do a research study, you have to have a question that you're asking, and then you're trying to answer it by your research. And the questions that doctors have are very different from the questions researchers have. And you have to phrase the question a certain way so it's answerable. So, for example, a doctor's question might be, at what age should we start mammographic screening? And you can't answer that question in research, and you have to ask the question in a very frustrating way, which is it beneficial to screen women with a mammogram under age 50 or not, so versus older. So it's really not the way doctors want the question answered. But we have to somehow bridge this gap that the people who have the questions about the patients in front of them are getting those answers in a reliable way. In a reliable way, that's enough. Okay, so we had this experience personally because of some research I'll show you that we're doing in ophthalmology. And what we've done is this: we take the clinical practice guidelines from the American Academy of Ophthalmology, and we take every statement that's made, every recommendation, and translate it into an answerable question. And then we go out and find out, are there trials here? Are there systematic reviews? And before we do this, and we also ask the doctors then in the field to rate the questions so that we have them prioritized for the order in which we should do the trials and the systematic reviews. And before we do this, we send the list of questions that we've derived from the guidelines out to the doctors. And the doctors get really mad at us. They say, these aren't good questions. Where'd you come up with these questions? And they're just the way you would have to ask the question to get to the recommendation that's in the guideline. So here's an example. In the clinical practice guideline, it says the ophthalmologist should discuss the benefits and risks of medical treatment with the patient, and we translated that statement into, does discussion of the benefits and harms of medical treatment with patients affect patient satisfaction? So it's a little different, but that's how we would have to ask it to answer it properly. So when we sent the list of questions out to doctors, we sent them out the list twice in a Delphi manner, and we asked glaucoma specialists then to rank all the questions that we had, and there were 45. And this is what we got. So these are all the questions on medical treatment. This is laser trabeculoplasty, this is filtering surgery, etc. And here's the question right here. And you can see it didn't get a very high ranking, but we were able to rank all the questions. Nevertheless, now if we go back and we do the systematic reviews because we think doctors have told us this is what we think is most important, but they really don't like our questions and they think that they're ridiculous, then we aren't going to have an impact. So here we are doing the trials, doing the systematic reviews that might not have an impact because it doesn't speak to the people who are treating the patients. Okay, so this is what I just told you, that we have a gap between the doctors and the questions they want answered and us, the persons doing the trials and doing the systematic reviews. What doctors want to know is what works best. And so what we found then, looking at the literature, is that doctors try to answer this question. This is complicated. Don't try to read it. I'll explain it. Don't read the inners. I'm just going to explain it because it's wrong, for one thing. But doctors are trying to answer the question again and again in a systematic review that they've done about what works best, but they haven't used the proper methods because of this question problem. So this is a systematic review done by some authors who are ophthalmologists, and what they did is they took all the trials that compared different medicines to treat early glaucoma, hypertension of the eye, ocular hypertension. And here are some of the drugs. I cut off the table so that the writing was bigger. There are even more drugs. And what they did is they took from each trial, let's say a trial compared timolol and latanoprost, then it put the data for that trial in these columns. Now the next trial compared timolol and timolol alone versus bimatoprost, and so it put the data in these two columns. And then the next trial compared latanoprost with bimatoprost, and it put the data in those columns. Well, you can't do that. You have to look at the randomized comparison. It's always what the trial looked at. So For example, if the first trial looks at A versus B, then you have to look at it as A versus B. If the second trial is also A versus B versus C, then you have to look at it that way. You have to look at them across this way. You can't put all the A's in one column and all the B's in another column and add them up, because those aren't randomized comparisons. And yet, when we look, don't worry, just squint. You don't have to look at the details. These are all the systematic reviews that we could find at the time we did this study. It just came out last week on medical treatment of ocular hypertension and glaucoma. And if they're red, the systematic reviews were done improperly. They either did it the way I just showed you, or they calculated the standard deviation incorrectly, or both. And what's interesting is most of them were done incorrectly. Some of them were done correctly. The ones that were done incorrectly often said, we use Cochrane methods to do this systematic review, Cochrane collaboration, but they didn't. So they knew what to say, but they were improperly done. And what's really interesting is when they were improperly done, they tended to cite, that's what's in red, other improperly done systematic reviews. And the properly done systematic reviews either just cited nothing, or they cited other properly done systematic reviews, with one exception. So it looks like rather than going to classes or whatever to learn about how to answer the question the way you have to address it, people are copying from one another the methods, and they're copying improper methods. Now, I don't blame this on the systematic reviewers. I blame this on the fact that we aren't talking to one another about the problem we have, the questions that are really a doctor's questions, what works best versus how do we do research, and we have to somehow bridge that gap. Okay, so in addition, the literature itself is not a reliable source of evidence, and this is where my work is mostly focused on various kinds of publication behaviors and bad behavior, really. People don't publish their findings. They may delay the publication. They may just publish some of it, that is, report some outcomes and not the others, or they may be missing details about what they really did. And you see this often. These problems aren't unique to clinical trials and systematic reviews. They go to all different types of studies and all different kinds of medicines. So it's pervasive, it's everywhere, and it's something that people are getting more and more worried about. So here is where you're at the mercy of what's in the literature. We're all at the mercy. So you may remember the COX-2 inhibitors and all the brouhaha about what wasn't published. So this was from the paper showing that, and it was, remember, looking at side effects, that it was ibuprofen versus celecoxib, and in fact it looked like the celecoxib had less side effects, gastric side effects, than the ibuprofen. And so it really looked fantastic as a way to go. But what was in the paper was only up to 6 months of follow-up. Once they looked at the internal company documents, they found that they had data up to 12 months. They just didn't publish it. And at 12 months, the drugs were the same. So what we're learning more and more as we get access to internal company documents, there's a lot that's being hidden. And so we can't rely on publications. I don't know what we're supposed to do, but relying on publications is beginning to look scary. So here, there have been lots of studies showing that findings may not be published, everything from ethics committees all over the world to small hospitals in Barcelona, where the publication rate ranges from about 20% to about 90%. And the trouble is that publication is related to the outcome, so that studies with positive results are more likely to be published than studies without positive results. So now, what are we going to do? Many things combine to determine whether an intervention is effective in populations and individuals, and we have this problem of not being able to rely on what we think of as knowledge, the published literature. So I'll just have a couple of slides on the Cochrane collaboration, my particular bias, which is a group that I work with, and we do systematic reviews. It's an international group. It's probably about 30,000 people now, and we've produced about 5,000 reviews that we keep up to date. This little logo up here for all trials shows that the Cochrane collaboration endorses registering all trials so that we have a denominator, a full deck of knowing every study that went on, even though it's not published. We will at least know that it took place. And this is an international petition. You can go on alltrials.net and sign the petition that all trials should be registered and published. The Cochrane Library, how many of you use the Cochrane Library? All right, I'm preaching to the choir here. So the Cochrane Library is a way to get access. Do you have free access here at the hospital? That's great. Okay. And this is just, it not only contains systematic reviews, completed reviews, but it has everybody else's reviews. It has a register of controlled trials and health technology assessments. So for example, when a relative of mine who'd been on bisphosphonates for 10 years said, should I stop? And she'd had 3 fractures, and I really didn't know what to say. I went on the Cochrane Library, no review. And it had been withdrawn because Cochrane doesn't allow any pharmaceutical money to help support its reviews. And in the old days, it had some, so that review was withdrawn. So I went on the health technology assessments and got a sort of answer. They didn't have really an answer for someone who had 3 fractures. Not a personalized question, but I got an approximate answer about it. So even if you don't find a Cochrane review, you might find another review that's relevant. So this is from Dr. Kramer. I really liked his a paper about the individual formerly known as patient, taking it from Prince, who is formerly known as Prince, but now he's the actor, the performer, the something formerly known as Prince. And this is how the patient is evolving, and the patient is going to become part of this decision making. The patients that we see know quite a bit about reporting biases, for example. They know about trial registration. That's not what it says on the web, and I'm sure some of you probably confront this in your practice. But patients go armed with information from the web to their doctor. I asked my own doctor because, you know, she's about my age, so she's getting kind of old. And I thought, I wonder if I still trust her because all the data show, you know, the younger the doctor, the more they're up to date. So I said, where do you get your information anyway? She said, well, I read JAMA, New England Journal. I said, no, that's not the right answer. And she said, well, my patients bring me printouts from the internet, and then I have to go look up and see what they're talking about. Okay, that's the right answer. So we, as part of our Cochrane Center, engage with the public in a group called Consumers United for Evidence-Based Healthcare. And I'm just going to show you one slide here about what we do at Q. We have distance education, which is free and open to all, including all of you. We have a Facebook group, free and open to all, and we post new papers all the time. It's not dumbed down in any way, but they have access to all new papers and resources. We have Clio, which is meant to be sort of like TED Talks, where we put videos about evidence-based healthcare. So, for example, we have Gordon Guyot talking about GRADE is up there. And these are some of our, we have distance ed courses that are free of charge to anybody. One on understanding evidence-based healthcare. It's about 6 hours long. The FDA is about 1 hour long. This is how to be involved in guideline development. It really isn't consumer-based. Anybody could use it. This is Clio, and then our Facebook. So all of those are resources that consumers have access to and use to stay up to date with what's happening in medicine. So just summarizing then, personalized healthcare to me is about using the evidence to make decisions, and we're starting to use, and that doesn't mean just genomics. It means looking at subgroups and risk prediction, and it also means bringing the person into the discussion with you. clinical trials play an important role, but the problem is that we have an incomplete record. This is being recognized, and I haven't talked about it, but there's a lot of effort going into now making all clinical trial data public, not just for systematic reviewers, but for others who might be interested. Cochrane Collaboration is a group of people. You have a Dutch Cochrane Center who might want to, who are very involved in making clinical trial data and other data more transparent so that we know what we're basing decisions on. And we have a lot of informed patients now, and they're well positioned to help with decision making and be part of everything that we're doing. So thank you.
Thank you. Thank you. Take a seat, please.
Okay.
Okay, thank you, Professor K. Dickerson, for this fantastic talk about the gap between evidence-based and personalized healthcare. And you gave some instruments for us, some tools that we can work on that important issue. We have asked 3 people to come to be a sidekick. Martelt, a student, Wout Feits, a urologist, and Bart Kiemenij, an epidemiologist. Okay, please take a seat. We will have time for some discussion now, 15 minutes, and the first minutes, those 3 sidekicks will open the discussion. Maybe I can give you the floor for the first question about what do you think as a clinician?
Okay, yeah, the first time I visited Johns Hopkins was in 1985, and many people from the urology department came afterwards. And I still discuss with our good friend, pediatric urologist John Gerard, the outcome and how he collects his data. And a lot of the data is collected either through telephone conference and things like that. And secondly, a lot of the data are unpublished in the clinical outcome or surgical outcome. Now, how do you see that we can solve this in the future?
Do you mean when you say they're unpublished that data from his patients or from clinical trials?
No, not clinical trials, just clinical outcome of a patient in my office who's coming for a surgical procedure.
Well, people are using more and more, want to use electronic health record. Is that what you're talking about, data that might be available that way? And they're wondering whether it might be useful to supplement what we can't get from clinical trials. For example, there may not be a clinical trial for the question that you have. But I think that that research is ongoing. The trouble we have in the States, I don't know about here, is that not everybody, including Johns Hopkins, has good electronic health records, and they aren't designed for research. So, for example, you have missing data. A patient may move, and so that's the end of that patient. So they really have to be a good electronic health record, first and foremost. That's a responsibility of the record. And maybe it's possible to use them for research, maybe not.
Yeah, second question maybe.
Okay.
Well, from the history, if I look back, there were a lot of papers coming out, surgical outcome, very good complication rate was in, well, 0 to 5%. Now, from a certain moment on, you see that after some publications with a much higher outcome, over the years, the long-term outcomes show an increasing number of complications, actually, up to 50%. Now, how do you have this in your methods to correct for this?
So one of the things that's being proposed, I didn't show data from a trial of ours on dysfunctional uterine bleeding where we compare endometrial ablation with hysterectomy, and a graduate student from Amsterdam is now working on the data where she's going to look at whether there are baseline characteristics of the patients that could have predicted who would need a hysterectomy, who had an endometrial ablation 4 years on down the line. And then that would be part of what you would tell the woman, well, since you have these characteristics, you might be at risk for having a hysterectomy. Do you still want to go ahead with the endometrial ablation? So that's what's being examined now with this risk prediction is can you look at some of the baseline characteristics, and that would have to be tested in another trial. And then that patient could be predicted to have that outcome.
Okay, thank you.
Okay, thank you. Martelt, you're a student. You almost finished your medical study, and now
right.
you will be a PhD student, I understand?
Yeah, that's right.
Have you questions for
Yeah,
Professor
I have.
Dickerson?
I was wondering if you make every effort you can to conduct a study with proper methods, how can you convince doctors to use the results and to make them change daily practice?
I don't know the answer to that. That's the question I have for all of you. Maybe you have some ideas, because as a person who's worked with medical partners for years, as a clinical trialist, first and foremost, we always wondered, does our study have any impact? And it often doesn't, and sometimes it does. And how can you determine whether it will have any impact? And so that's why I've gotten interested in this question, asking the question, or working together so people understand that you have to ask the question a certain way. Anyone I talk to in evidence-based healthcare says that this question is the hardest part of our communication. And so I ask all of you, how can we do it better? Maybe that's the problem. Maybe it's that we seem to be asking questions that aren't what you really want to know.
And one of the problems is you learned this is that all the literature is not reliable, and you are working on that. That's the first step, of course, because otherwise doctors will not be motivated to use the evidence if they think the evidence is not reliable.
Well, and I think what I've seen, I don't know what happens over here, but often the teaching in the older generation, I think things are changing, but they're taught to go and do a quick Medline search and say, oh, I found a paper that shows X, rather than look for a systematic review. And it is, in a way, more compelling to look at a single trial. It's people you know who've done it, and maybe you don't know the people who've done the systematic review. They live in South America, you've never met them, they aren't part of your community. That's something we're finding in the US is there aren't as many people in the US involved in the Cochrane collaboration, and so they may not see people they know doing the systematic reviews, and so it's not as believable to them as a single trial where they know the investigators. So that kind of thing, personal recognizance, may make a difference.
Okay, thank you. Bart, you have a question.
Yes, thanks, Jan. I would like to ask how long we should wait for a systematic review. Because I think there are hundreds of research questions, hundreds of situations which you won't get any, probably within the next decade, within the next 20 years or whatever. There may even be situations like in personalized medicine for cancer screening or whatever, in which people are now working with these genetic markers which have not that high penetrance, that predict very strongly. So you have to make combinations of markers and that kind of stuff in order to identify high-risk groups. But you need such large research groups to get that information, so there will probably not be any second study in order to prove that it is the right risk assessment tool. So how do you do that in such situations?
So are you asking me about that situation, or how long should wait for
in
systematic?
general, because you're talking about clinical trials, but there are many research questions in which you do not get any clinical trials, of course. And if you get one, maybe there is just one and not 2 or 3 or 4.
Then those are the data. I mean, in the Cochrane Eyes and Vision group, the group with which I'm most familiar, I would say 1/3 of our systematic reviews are what we call empty reviews. There are no trials. So somebody thought it was an interesting question, but there are no studies. And so we found, though, that as soon as we set that out, it's not a waste of time, that then investigators who do trials see the opportunity and right away jump in, and then the next time when we update it, there are studies. That doesn't mean there will be 2 studies, but is one better than none? Probably. If it's too small, I don't know. In terms of can we do all the systematic reviews, I think that's a great question. In the US, we don't invest a lot of money in doing systematic reviews, and I don't know why. Somehow it just is not seen as interesting compared to doing that clinical trial. And I'm reminded of going out to dinner with some friends, and 3 clinicians, my husband and the 2 friends, and one of the friends was on call, and he got a phone call. I don't even think he was on call, but in the middle of dinner he had to take the call. He wasn't on call, and I said, why did you take that call? You know, we're sitting here having dinner and you aren't on call. And he said, a clinical problem will always be more interesting to me than sitting around having dinner, you know. And, and I think it's like that with systematic reviews, is that it's just not as interesting as a clinical problem that is in a primary study. And so when it goes to funding, we may not fund the systematic reviews we really need. They're expensive, because you're trying to find everything, and they take a long time. So I think we do, I'm speaking of the US, I don't know what the situation is here. We really need to fund those systematic reviews and understand that that's a priority to know what's happening.
Okay, thank you. Are there any questions from the audience? Okay, please state your name and how.
I'm Bart Post, I'm a neurologist and also epidemiologist. And I wanted you to ask you whether you could comment on the role of shared decision making in personalized medicine.
I think,
Good
do you
question.
do shared decision making here, or some people?
We have to do, but
Yeah. Well,
always-
yeah. I mean, it depends what we mean by shared
should-
decision making, right? Also, first of all, I think patients are different. Some people, and you know that better than I do, some patients just want to be told what to do, especially in a difficult situation or something they know nothing about. Others are much more actively involved. I'm one of those active people who asks a lot of questions. But if I trust my doctor, I'll probably say, okay, I really value your opinion, tell me what you think I should do. But in terms of using some of the decision aids, I think they're fabulous, and I don't know how much they're used. My sense is they're not used that much, and that they really could be useful. I have a story with my dad, actually, who had to make a difficult decision about heart care, and so right away, my mom was really excited about this, that they live near the Foundation for Medical Decision. They have a new name now, and she ran up and got the CD, and it was from the Mass General, which meant that it could do no wrong, and they put it in the DVD into their TV, and they loved it. And what my mother said was, I really loved seeing all the patients talk about their decisions, and my dad said, I really loved all the statistics. And they made a decision, so they loved different things about it. They made a decision, and then the next day went and talked to his cardiologist and came home with a completely different decision.
Yeah.
And so I think it seems great, but I guess it's not like being there.
but it is a method to involve patients in applying the knowledge
Yeah,
obtained from evidence. Huh?
I think it's better than not doing it, but I don't know if we're there yet in terms of the effect that we want it to have being had.
Thank you. Other questions? Okay.
Ewart van Dijk, I'm a neurologist as well. I think that one of the problems is with the translation of evidence-based medicine to personalized medicine is the external validity of the trials. Is the result of the trial also good for my patient in my outpatient clinic? And I think that when you do registries like FDA does or Kaiser Permanente does, could validate the RCTs. Do you agree with that?
So what you're saying, I just make sure that I've got it right, is the main problem is the generalizability of randomized trials.
Yes.
I mean, this is a refrain that we hear pretty often. Someone said to me once, and I thought it was great, when he said it, it really clicked with me, which is that he said, are the patients in your trial so different? Is the setting so different? Is everything so different in that trial or the systematic review of trials that you can't, that what's in those data is better, no better than nothing, and you're going to go with nothing rather than what's in the trial? Are they just so different? And I think most trialists, when you talk to them about them being not pragmatic and not generalizable, feel as if they have tried to make their studies realistic. Now, drug studies going for drug approval may be different from the trials I've done have mainly been surgical, so it's maybe different than some of the drug studies. But, you know, I think some data from good randomized trials may be better than just taking our not looking at the evidence at the same time. But I know this is a real concern of clinicians, and so that's one of those areas we have to understand one another a bit better.
Okay, thank you.
Do you think it's necessary to do these phase 4, or how you call them, post-marketing surveillance study to validate the results of the trials? Or do you
I think those studies are great, mainly for adverse events that you might see later on. But we can't do a trial for every single possible person.
Your question is related to the effectiveness, I think, not
Sure.
only the safety.
For effectiveness, yeah. Well, a non-randomized follow-up, you mean?
Yeah.
Or, yeah, I guess that's not where I'm coming from. I think it's important information, but probably not. You know, years ago, and I was involved in more reproductive trials, and there was a trial of bed rest for twin pregnancy, I think it was, and it was done. There was one in, I think, Zimbabwe and one in Ireland, and you know, American doctors then would say, "Well, are these relevant to us?" Well, I don't. I think so.
we give dangerous drugs to people who are not in the trial, just because of the external validity of the generalization of the results.
It's always interesting to see how they did. People in my field will always talk to you about the Women's Health Initiative and how the observational studies. I mean, the observational studies there showed for a very low outcome, low rate outcome, for example, breast cancer, the observational studies were similar to the trial. But for the cardiovascular outcomes, which were more common, it was quite different. So it was a different population.
Okay, thank you. We have time left for one question. Okay, Theo.
My name is Theo van Achterberg, Professor of Nursing Science. I think you very rightfully pointed at the publication bias thing, but I wonder what is the acceptable answer. So when would you say there's no use for this review? I mean, you cannot use it, it's just too biased, or when is it acceptable risk of bias? Because that's very hard, I think.
Yeah, I don't know the answer. I think it's why systematic reviews are the hardest research I've ever done, is there's so much judgment. And so I would say you have to work as part of a group. You can't make these decisions alone. When we teach systematic reviews, we make the students work as part of a multidisciplinary group because of all those judgments. And when the studies you just aren't sure enough that you have the correct data, that's one of the hardest decisions to make. I don't have an answer that's across the board. You just have to make your judgment for that situation.
Okay, so we all struggle now.
And you can change your mind, you know. They're updated every couple of years, and so if more information comes through, I think the Tamiflu example is, you know, in the BMJ, any of you who followed that, you can see how the results were really changed on the basis of the unpublished information from Roche. So it can really, I have to say, maybe I shouldn't say this in public, my friends are shocked when I've said it to them, but it does make me believe more and more in the clinical care that I get, and the evidence is only a piece of that puzzle. It's not the whole thing. It's the clinician's experience counts for a lot.
Okay, thank you.
Thanks.
Okay, everyone, thank you, but especially, of course, Professor K. Dickerson.
Oh,
thank you very much. We have brought a little book. It's about our famous new Rijksmuseum that has recently been reopened.
Thank you. Wonderful.
Okay.
Fantastic. Thank you very much.
Thank you. Ja. Dames en heren, dit is het einde van de 14e Grand Round. Zoals u weet is er nog tijd om even een glaasje te drinken met elkaar. De volgende keer zal niet zijn in juli, de derde maandag van juli, want dan is het zomervakantie en er zijn heel veel mensen van ons weg. Maar zal in augustus zijn. We hebben dan weer een bijzondere spreker. Dan zal professor Van Est, degene die de zwaartekrachtsubsidie heeft gekregen, een verhaal vertellen van organische chemie. En die zal praten over nanotechnologie en de impact daarvan voor de medicatietoediening bij met name oncologische zaken. Uitermate boeiend terrein. Ik nodig u allemaal van harte uit daarbij aanwezig te zijn. En natuurlijk aanstaande donderdag, wanneer professor K. Dickerson een andere presentatie zal gaan geven bij de Valkhof-lezing. De echte reden waarom ze eigenlijk in Nederland is. En bij die Valkhof-lezing zal ze gaan praten over patient empowerment. Dus allemaal hartelijk welkom, 1:30 in het auditorium. Oké, dank u.